Okay, well, I think we'll make a start. Good afternoon, everyone, and welcome to teaching today. Today, I wanted to talk about a subject we haven't talked that much about specifically, and that is upper airway obstruction in infants and children. But it's a very common problem, and as pediatricians, we really need to understand the different causes of upper airway obstruction in children in detail, and we need to be able to make a distinction between what upper airway obstruction is chronic and what is acute, what is supraglottic and what is subglottic, what is infective and what is non-infective. So today I just thought as a start we'd go through the different causes of upper airway obstruction, and I'll show you some videos of a couple of children anyway that have upper airway obstruction and some other photographs that help illustrate the clinical signs that different sorts of upper airway obstruction manifest. And so I'm going to be showing you a couple of cases and some other X-rays and MRI scans, and we'll try to work through the different causes of upper airway obstruction. Right. The first the first case was a 3-year-old boy, and he had become unwell for the first time about 8 days before, and just with a cough and a cold, the typical symptoms of an upper respiratory tract infection. And then 2 days before he presented, he developed a very high fever, and he was much more unsettled, and he was complaining of severe pain in his throat. In fact, he couldn't eat very much. He wasn't drinking or swallowing for the previous 12 hours, and his parents noticed that he had difficult breathing and he was snoring a lot, even when he was awake, and much more when he was asleep. He was unable to talk and he couldn't swallow. And these are symptoms that they should alert you to a certain type of upper airway obstruction. And I want to go through that today. When he presented, his temperature was 39.6 degrees, so a very high temperature. So we're already in the area of it's likely to be acute and it's likely to be infectious because he wasn't unwell before. It's not chronic, some form of congenital upper airway obstruction. It's likely to be acute and it's likely to be infective. And there's some other features about this, particularly the severe throat pain and the snoring and the difficulty swallowing that gives you an indication of exactly where the upper airway obstruction is. And this boy was hypoxic when he lay down or when he fell asleep. His oxygen saturation would fall. I want to show you the video of this boy now, and I think you'll see that what I mean by the snoring breathing he's got and the fact that he looks quite toxic. So just watch this video and then we'll talk about it. Yeah, you'll notice that every time he's got a snore, and the snore is expiratory in nature. It's not an inspiratory noise, it's an expiratory noise. When he's breathing out, he has a snore. And and you'll notice that when he falls asleep, his snore gets louder, and then he almost seems to stop breathing, and then it wakes him up, and he then breathes again, but he's still got that snore. And this is very typical of a certain type of upper airway obstruction, that is supraglottic obstruction, obstruction of the airway above the glottis. So I'll show you a bit more of the video. You'll notice that he's, oops, oh, sorry. You notice that he's breathing with when he coughs, he has it appears like he's got throat pain, and he grimaces when he coughs, and he has a strong expiratory snore. He's frequently trying to keep himself awake because whenever he falls asleep, his airway obstructs, and I think so. We'll just finish the end of the video. Okay. All right. So you notice several things about this child that when he falls asleep, he obstructs. He's got his mouth is open all the time. He's actually not swallowing his saliva. He's drooling his saliva, and that is a characteristic feature of some form of supraglottic obstruction of the airway above the level of the larynx, the laryngeal inlet, the vocal cords above the vocal cords. And if you think about the structures that are above the vocal cords, there's the epiglottis, and so he could have epiglottic swelling or something similar to that, which is like a retropharyngeal swelling that's obstructing the supraglottic part of his airway. That your tonsils are above the larynx as well, and if you have severe tonsillar hypertrophy, then you can look like that with the appearance of supraglottic obstruction. Um, and sometimes if there's an abscess, for example, on the tonsils or a lot of lymph nodes in the supraglottic area, uh, big adenotonsillar hypertrophy, then you can have that type of breathing, that evidence of supraglottic obstruction. If you saw a child like that, then you've got the differential diagnosis of something that's likely to be above the glottis. As I said, epiglottitis or epiglottic swelling or retropharyngeal abscess or a foreign body in his upper airway above the laryngeal inlet or adenotonsillar hypertrophy. They're really the main things that will cause that. And given that this child's temperature is 39.6 and it's an acute problem, then it's likely to be some sort of infection. And I just want to show you the lateral neck X-ray that you might see in such a child. I want to try to explain how to interpret lateral neck X-rays. They're often people have difficulty interpreting them, but if you're looking for evidence of airway obstruction, the things you're looking for is firstly the retropharyngeal airspace, and the retropharyngeal airspace should be no more than one width of the vertebral body. So this is the vertebral body. And in fact, the rule of thumb is zero point 0.6 of the vertebral body. So here's the distance of the vertebral body and the retropharyngeal airspace, this soft tissue space in the retropharynx, in the anterior to the anterior to the vertebral bodies, should be no more than just one of these vertebral body spaces. If it's more, like this is more than one vertebral body, then it's likely that there's a soft tissue swelling there behind the retropharynx. And that's what you typically see with a retropharyngeal abscess. And in this case, I've measured it. It's 11 millimeters is the vertebral body at the widest diameter, and the retropharyngeal airspace is 15 millimeters or 14.9 millimeters. So there's a very substantial swelling of the retropharyngeal airspace. This is normal. The X-ray on the right-hand side is normal, and you can see that the vertebral body is much wider than the retropharyngeal soft tissue space. The airway, the black part, is wide open, and the soft tissue space behind the retropharynx and in front of the vertebral body is relatively narrow, whereas here the airway is open, but the retropharynx is behind the retropharynx. There's a large swollen soft tissue space, and that's, as I said, that's typical of a retropharyngeal abscess. You can also look at the epiglottis in such pictures, and this is the epiglottis there. You can just see the epiglottis just uh, at the just above the trachea, and in this case, the epiglottis is a bit swollen. Right, so this child's got a retropharyngeal abscess and epiglottic swelling. You can see how the epiglottis is more thick than on the normal X-ray on the right. On the left, the epiglottis is thick, and on the right, the epiglottis is actually a very narrow structure. You can't always see the epiglottis very well. In the abnormal one, in this case, you can see it, and you can see just below that laryngeal inlet, there's also a large soft tissue swelling. So this is a large, likely to be retropharyngeal abscess. Sometimes in these situations, you'll also see some free gas within that soft tissue space in um, the soft tissue space in front of the vertebral bodies. You'll see some free gas, little locules of gas, and that suggests that there's a infection there producing gas, for example, like a clostridial infection or some sort of infection that's producing gas. Either way, this boy's got an enlarged um, retropharyngeal soft tissue space and swollen epiglottis. So, as I said, the prevertebral soft tissue shadow should be no more than about 2/3 of the vertebral body. So here it's more than the entire vertebral body, and it's said that at C3 it should be no more than 6 millimeters, and it's way more than 6 millimeters, 15 millimeters. If the child's in expiration, it can be a bit more because all the tissues are a bit compressed. But this is what you can see here is clearly abnormal. So this boy had both epiglottitis, a swollen epiglottis, and a retropharyngeal abscess. And this is what the airway looks like when you've got um, uh, epiglottitis or a retropharyngeal abscess. This is a normal airway. You can see the normal epiglottis. You can see when you do a laryngoscopy, you can see the vocal cords and you can see the laryngeal inlet, and there's the true and the false vocal cords and the epiglottis. And here is where you've got the posterior pharynx is very swollen, and the epiglottis as well is very swollen. So this is a large retropharyngeal abscess with epiglottic swelling. And here you can see that unlike in the normal view where you can see very clearly the laryngeal inlet, you can see all the way down the trachea. In this one, it's very hard to see the laryngeal inlet, and you can see how it's almost completely obstructed by the swollen retropharynx and the swollen epiglottis. Children who have retropharyngeal abscesses it's really important to diagnose because they almost all of them need surgery. Often we treat these patients with antibiotics, but they almost always need surgery to drain an abscess that's there. They present not only with the features I've mentioned before, but they often present, older children will present with neck pain. More than a third of them present with neck pain, and sometimes a stiff neck. They'll have a wry neck or a torticollis where their neck is stiff and they can't often extend to look up. That's again at least a third. Some of them have a mass in the lateral side of their neck because the abscess is so large. They almost all have fever and sore throat and some respiratory distress and stridor, or at least that snore, that expiratory snore that I mentioned. In large series of retropharyngeal abscesses, more than 60% require surgery, but even those who are treated initially with antibiotics alone, more than half of those children also require surgery because of a failure to achieve good source control. Now, sometimes when a child's got a retropharyngeal abscess, there's not pus to be drained immediately. It's like a cellulitis of the mucosa of the retropharynx. But often, as days go by, an abscess develops that requires drainage. But more than half the time, there's an abscess there that benefits immediately from drainage, and for the rest of the time, sometimes an abscess develops. So it's always a condition that should be managed in conjunction with an ENT surgeon or a surgeon who can drain an abscess in the retropharynx. But we can make the diagnosis by the clinical features, which I've shown you, especially that expiratory snore and the toxicity, how unwell and toxic that boy looked, and the throat pain, and then looking at a lateral neck X-ray and seeing that that large retropharyngeal soft tissue space. They're the ways to make the diagnosis, and then the treatment is antibiotics and surgery. The investigations, as I said, get get a lateral neck X-ray. Now, some children in the early stages will have a normal retropharyngeal soft tissue space. It won't be that swollen just yet because it's cellulitic rather than an abscess formation or rather than a sort of inflammatory mass in the retropharynx. So it is possible to have a retropharyngeal abscess or retropharyngeal infection without having an abnormal X-ray. But always, if you've got an abnormal X-ray like I showed you, then the child's got a retropharyngeal abscess of some sort, or a retropharyngeal hematoma, some form of swelling of the retropharyngeal space. Do a full blood count and take a blood culture, and then you really need to be referring these patients to the ENT surgeon or a surgeon who can drain the retropharynx and get the anaesthetist involved if you have an anaesthetist or the intensive care unit, because sometimes these patients need very close monitoring, and as you saw from the laryngoscopic view of this boy's larynx, it was very obstructed, and without drainage would likely completely obstruct the 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 bacteria causing these retropharyngeal abscesses. They're often group A streptococcus, sometimes Staph aureus, sometimes other bacteria, but ceftriaxone will usually cover it well, and usually the patients need a week of ceftriaxone and then sometimes step down to some amoxicillin or augmentin. Um, I usually treat them with dexamethasone as well, but that antibiotics and dexamethasone won't manage sufficiently a retropharyngeal abscess that really requires surgical drainage. So it's very important to get the surgeons involved to start with, and to make sure the airway is secure. This is another child with a retropharyngeal abscess. You can see again the soft tissue space behind the retropharynx is wider than the vertebral body. It's so there's an abscess there, and in this child there was a swelling. And maybe it's a bit hard to see, but a swelling in that space in the lateral neck. So sometimes you can palpate a swelling, sometimes you can't. Um, it's yeah. There are a few other things that can cause this, but there's not many other things that will cause a very swollen retropharyngeal soft tissue space like this. A retropharyngeal abscess or a hematoma being the only things. Yeah. Sometimes this is a CT scan of a child who also had evidence on plain X-ray of a large retropharyngeal soft tissue swelling, and you might wonder what this is. Well, this could be a large retropharyngeal abscess as well, but in fact this was tuberculosis, so that was a caseating inflammatory mass in the retropharyngeal space. So very occasionally this can be due to tuberculosis. That, I think that's very rare, and mostly they're bacterial group A streptococcus or strep anginosus or some staph infection. So usually standard antibiotics, ceftriaxone or even benzoyl penicillin can treat most of these patients adequately. But occasionally you'll see a child who's got TB retropharyngeal abscess. I mentioned other things. If you've got a child who's got that evidence of a supraglottic, so the glottis is the laryngeal inlet, and evidence obstruction above that is like epiglottitis or retropharyngeal abscess. You've also got tonsils there, and there can be an abscess in the tonsils. It's a continuum of infection between a retropharyngeal abscess and what is called Quinsy, which is a peritonsillar abscess. And as you know, the tonsils are lymphoid tissue, lymph node tissue, and they help filter out bacteria and manage infection. But often we can get tonsillar enlargement in the cervical nodes or the axillary nodes if you've got a local infection. Well, if you've got a local infection in the throat, then that can lead to an abscess within the tonsils. And there's a big difference between finding inflamed symmetrical tonsils, as you can see on the left, and a Quinsy or a peritonsillar abscess. This is a peritonsillar abscess you can see on the right-hand side, and there's an asymmetrical swelling of the right-hand side of the throat compared with the left. The uvula is there, but there's a swelling of the right-hand side. This is Quinsy. The Quinsy is mostly due to group A streptococcus, and most of them, almost all of them, are actually sensitive to benzoyl penicillin. So, but still, sometimes a Quinsy needs surgical drainage by the ENT surgeons as well. So Quinsy, retropharyngeal abscess, epiglottitis, they're all supraglottic causes of airway obstruction. The other ones are obstruction with enlarged lymph nodes, which is a bit similar to a Quinsy or a severe tonsillitis, and occasionally a foreign body that gets lodged in the supraglottic airway, which can also cause a sort of that type of presentation, that snoring, that throat pain, etc. There's another, I've talked about supraglottic obstruction. Now want to talk about glottic or infraglottic obstruction. And I want you to, this is a video of a little girl who had a different sort of airway obstruction. And I want you to try to see how they're different. And so you'll be able to recognize supraglottic obstruction from subglottic obstruction. That's the one main thing I think we can do clinically. We can make that distinction. And so just watch this video. Again, it's a bit of a long video, but you can watch it and just see the signs that this girl has and compare that with the signs that the previous boy has. Here we go. I want you to notice the phase of respiration that the child has the noisy breathing. The stridor is in an inspiratory phase predominantly. Every time she breathes in, she's got stridor. She also is she's agitated, but she's not as toxic looking as the previous child. And she's got a cough. You notice she's got this a cough that sounds well. People say it sounds a bit like a dog barking. I think it's a sort of high pitched cough that goes along with her stridor. It's I hope you can see that how the two different types of obstruction are different. Supraglottic with an expiratory snore and subglottic with an inspiratory stridor. We'll just watch the rest of the video. Okay, so that's croup, which is laryngo being at the level of the larynx, tracheobronchitis. So this is obstruction at the larynx and below, laryngotracheobronchitis, and it's an inflammation of the mucosal lining of the larynx and the vocal cords and especially the subglottic trachea and the bronchi. And mostly these are due to a virus. And the common virus causing these croup is parainfluenza. Some other viruses in during viral outbreaks can also cause croup. We see quite a bit of croup with respiratory syncytial virus, the common cause of bronchiolitis, also with adenovirus, another virus called human metapneumovirus. It's again quite common with influenza. If you have an influenza outbreak, then some children will get croup. And we saw quite a bit of croup during the COVID pandemic with the COVID virus. And also when you have if there is a measles outbreak or you see some children with measles, some kids with measles will also get a laryngotracheobronchitis and quite severe measles related croup. But again, in most winters, most outbreaks, it's usually due to paraflu. If you get a lot of parainfluenza in the community, then there'll be some children who are getting croup. And the characteristic features different to a retropharyngeal abscess or epiglottitis. It's usually they have a barking cough and they have stridor. It's not an expiratory grunt or an expiratory snore. They have an inspiratory stridor. It starts inspiratory anyway. I'll mention what happens after a while. They have a hoarse voice or a cry, a bit similar to those with a supraglottic obstruction, but it's a bit different. Sometimes these children, because they've got a virus, they can also have a bronchiolitis-like illness or a pneumonia, a pneumonitis from the virus. And so they may also have widespread wheeze or crackles in their lungs because the virus is also affecting the lower airways as well. And they'll always have respiratory distress and they may have fever. Sometimes they have a high fever, but usually they're not as toxic as what children with a retropharyngeal abscess are. It does differ somewhat, but usually not as toxic. If they're very toxic, then you need to think this could be a bacterial infection like a bacterial tracheitis. But again, 95% of them are viruses. You can classify croup into varying degrees of severity. And this is important because it dictates whether how we manage such patients. If croup is mild, then the stridor is present only when the child's agitated, when they're getting agitated, but when they're at rest, they don't have any stridor. They have no stridor at rest. And you could see that the child that I showed you in the video is far more than just mild croup, because that child had stridor even when at rest. She had quite a severe stridor, didn't she? Children with moderate croup have stridor at rest, but sometimes when the stridor is when the obstruction, the airway obstruction is getting very severe, sometimes the stridor becomes softer. It's not always that a very loud stridor means there's very severe obstruction. Sometimes it can do, but beware of a child who has had a prominent stridor and then their stridor disappears. Look for other signs of obstruction is the main thing. Children with severe croup have stridor at rest, and they have marked inspiratory indrawing of the suprasternal and the intercostal and the subcostal soft tissues, intercostal indrawing and chest indrawing. So that's severe croup. And I think you would agree that this child I showed you at least had severe croup with marked inspiratory indrawing, chest indrawing, and stridor at rest. And then there's children that have very severe croup, and that's just an extension of that. Any child who's hypoxic with upper airway obstruction has evidence of severe upper airway obstruction, because unlike with pneumonia, you can there are reasons why a child's hypoxic. If you've got croup or retropharyngeal abscess and the child's hypoxic, then it's likely to be that the airway narrowing is very marked. And so any child with cyanosis or has reduced air entry, as the children are getting worse, often they go from just having a soft inspiratory stridor to having both an inspiratory stridor and an expiratory stridor. Not always, but sometimes they do. So I think beware of any child who's got airway obstruction, stridor at rest, cyanosis particularly, regardless of whether it's a supraglottic or a subglottic obstruction. That when you're looking after a child with croup, it's really important to try to minimize their distress. If they've got stranger anxiety, if they're upset or agitated, then their stridor will be worse. So always, if you can, keep the child with the mother or their carer to reduce their distress. Try to provide a very calm environment for the child, and usually don't force a child with airway obstruction to lie down. That's very detrimental. They're more likely to obstruct. Just allow them to assume whatever position of comfort that they want to. The first child I showed you was sitting up, and he was much more comfortable sitting up and leaning forward because his airway was more open then. Most children will assume a position of comfort that minimizes their airway obstruction. The second child I showed you, when she had worsening obstruction, she lay down almost face forward so that her airway was a bit more open. So children will, as I say, adopt a position of comfort that minimizes their airway obstruction. So don't force them into another position because one, it'll get them agitated, and two, it won't be as effective, won't be as adaptive as the position they usually find themselves in. The treatment for croup is um, is nebulized adrenaline, especially severe croup. If the child's got stridor at rest, then use adrenaline. And before we had adrenaline, in fact, those videos were taken in the days before adrenaline was being given to children. But before we had adrenaline, children would just get more and more obstructed, and then they would usually need to be intubated. But now for more than 95% of children with croup, it settles with adrenaline and steroids. So they're the two treatments we use: adrenaline, nebulized adrenaline. And I just want to go through the types of adrenaline. It's all the same type of adrenaline, but the strengths of adrenaline. This is something that's often not appreciated, but the strength of adrenaline that comes in the small vials, that's called 1 in 1,000 adrenaline, right? It's 1 milligram per mil. So in every vial is 1 milligram. In the larger vials, sometimes they're brown and sometimes they're clear. Then that's 1 in 10,000 adrenaline. So there's 1 milligram of adrenaline in 10 mils. All right, so you need to know what type of adrenaline you're actually giving. Sometimes 1 in 1,000 also comes in bottles like this, adrenaline solution for nebulization. But if you're using 1 in 1,000 adrenaline, then you use 0.5 mils per kilogram. So a child like the child I showed you previously might be 10 kilos. So you're going to give 10 times 0.5, which is 5 mils of adrenaline. So you put 5 mils of adrenaline, which is 5 ampules of adrenaline in a nebulizer, and then and nebulize that. And children these days, children, they typically respond quite well. If they don't respond, then they need much more urgent treatment, but usually children will respond, and sometimes the response it can last for many hours. It can even last a day or so, but sometimes it can last a much shorter period of time. And if you have a child who's needing repeated doses of adrenaline, then they need to be in an intensive care unit with consideration for whether or not they're intubated. But adrenaline works fairly quickly, usually often by the time the adrenaline nebulization is finished and a minute or so has elapsed so that the child is calm again, then usually their stridor will be better. Another thing is, I see a lot of children getting worse because the doctors or the nurses are trying to hold the mask very tightly over their face, and that makes them very agitated. That they do get most of the adrenaline that way, but they just get more agitated than is worth. And so sometimes they can even obstruct completely if you're holding a mask tightly over a child's face, and even when you're trying to do the right thing and giving them adrenaline. So for children that are a bit sensitive, I tend to hold the mask quite close by and allow the adrenaline to just waft up into their mouth and nose. They'll get enough of it, and then they get upset less. So if they're lying down, then hold it just below their face, and the nebulized adrenaline will waft into their airway, and they'll get the effect, even though it won't be a maximal effect. They'll still get the effect, and they won't have the detrimental effects of someone trying to hold a mask over their face. The um, the other treatment for croup these days, the adrenaline works quite quickly within minutes, and steroids work. They take some hours, like usually about 4 hours to have an effect. And so, if you give dexamethasone or prednisolone when a child presents and you give some adrenaline, if they've got stridor at rest, then usually by the time the adrenaline is worn off, then the steroids have kicked in, and the child's got some reduction in airway swelling because of that. The doses of dexamethasone, if that's what you've got, is 0.15 milligrams per kilogram. If you've got a child who's very severe, then I usually give a larger dose, 0.6 milligrams per kilogram. If the child's needing intubation, then give them a larger dose. But that's rare. Mostly 0.15 milligrams per kilogram, usually twice a day is enough, or prednisolone, a milligram per kilogram, again twice a day for 2 to 3 days. In children with mild to moderate croup, that's all they need. And 90% of, or more than 95% of children with croup these days settle with these measures, with some dexamethasone or prednisolone and nebulized adrenaline. And you can keep giving nebulized adrenaline. It has a very short half-life. And as I say, sometimes it's effective for many hours, and sometimes a child might need adrenaline every few hours for the first 24 hours or so. As you probably know, often with croup, the child will often get worse overnight if it's quite a cold environment, then the cold night air can make it worse. If there's a humid environment, that tends to be better, actually. They tend to get less severe obstruction in a humid environment rather than in a dry environment, dry, cold environment. So you should give nebulized adrenaline if the child has stridor at rest. And as I said, 0.5 mils per kilo per dose. Steroids, we talked about the dose. If a child's got worsening obstruction, if they've got hypoxemia, if after the first dose of adrenaline and steroids and the child's hypoxic, then that's an urgent situation. They need to be in an ICU where they could be intubated or where they could have their airway protected. It's okay to give those children oxygen, but don't give the child with mild or moderate croup oxygen. If you do that, then you mask one of the important signs of upper airway obstruction, and you might miss it. You might miss the fact that the child's getting severely obstructed. If the indications for intubation also include signs of very severe croup or severe croup that's not responding to adrenaline or steroids. And if a child's got reduced conscious state for any reason, then they've got very severe croup, as long as it's not just their normal tiredness. And these children often have, they often tire out after a while because they have trouble getting to sleep because their obstruction can be so severe. So don't wait until they have airway obstruction or have a respiratory arrest. They need to have the treatment that I've mentioned first, and then if they're not responding to that, then they need to be in an ICU where they can have an anaesthetist or an intensive care specialist manage their airway and intubate them. As I say, only that happens to less than around about 5% of all children with croup, but it's an emergency when it does happen. So you should manage in the ICU any child with severe upper air obstruction for any cause, for a retropharyngeal abscess or Quinsy or epiglottitis or croup. You should manage them in the ICU. Any child who needs more than 2 doses of adrenaline, they should be managed in an ICU environment, a high dependency area where they can be carefully monitored. And any child who has upper airway obstruction who needs oxygen, as I said, it's an indication of severity of airway narrowing, and they need to be managed in an ICU. Sometimes if you've got a child who's very sick with airway obstruction, there's something that you can look for as an indicator. I just wanted to look at the oxygen saturation trace where it says 97. Just watch this trace and see what happens to it. You can see that the trace goes up and down. I don't mean the normal sort of fluctuations of the plethysmographic trace, but it goes up and it goes down, and that's with the phases of respiration. And when you see that, that's usually a sign of quite severe airway obstruction. You can see it in a number of different cases of airway obstruction. It's just a sign on the pulse oximeter that the child is likely to have severe airway obstruction. But you'll be able to tell from those clinical signs I showed you. There's a few other causes of airway obstruction. We've talked about the acute infective causes. There are some others, and I saw, for example, in the last week, a child who had severe foreign body in the airway causing obstruction. There's this congenital problem, such as a congenital hemangioma of the airway, and this is another congenital problem called a vascular sling, which is where the pulmonary artery wraps around the trachea, so you get like a strangling of the trachea with the pulmonary artery. It's just a developmental anomaly that sometimes can look very much like a child's got severe croup. It's subglottic, so it looks a bit like tracheal obstruction. Or if a child's got a mediastinal mass that causes tracheal compression, that can also look like croup. And I've seen many children that have got mediastinal masses that get treated for croup and it doesn't get better. If they've got a hemangioma, just like a strawberry nevus or something of the trachea, or if they've got, this is more chronic, non-infective, but if they've got laryngomalacia or tracheomalacia or something they're born with, that can cause it as well. So if you see a child with upper airway obstruction, decide, is it chronic or is it acute? Is it likely to be infectious or is it not infectious based on temperature, toxicity, full blood count, the way they look? And is it supraglottic or is it subglottic? And you know now the clinical features to identify each of those. This was a child who had severe airway obstruction, and you can see the mediastinal mass, you can see the widened mediastinum, but you can also see that his trachea is reasonably well open, but you can see, I hope, also large swellings in the supraclavicular region and in his neck. And this was a child who had a T-cell lymphoma, and you can see also the swelling in his axilla. So he's got very large lymph nodes that were also obstructing his airway, both the supraclavicular nodes and the cervical nodes, and also his tonsillar nodes obstructing the airway. So if you see a child who's got this sort of thing, they may have a lymphoma or a leukemia. All right, so the main things are, in terms of the differential diagnosis, remember, is it chronic or is it acute? Is it infectious or is it not infectious? Is it supraglottic or is it subglottic? And if it's an acute infectious problem, then acute febrile problem, then it's likely to be croup, and most of those are viral, rarely bacterial, occasionally Staph aureus, but rarely bacterial. Or it's a retropharyngeal abscess or a peritonsillar abscess, or yeah, that's the one to look out for. Or think about a foreign body, because that they can be easily addressed. Other types of airway obstruction, like congenital causes, they become quite apparent because they're on history, they're more chronic, and the child's not toxic or febrile. We've learned how to assess such patients in terms of, is it supraglottic or subglottic, and to assess the severity of the airway obstruction, and from mild, moderate, severe, and very severe. We've learnt about the emergency treatment such children need and when to escalate to when such children need monitoring in a high dependency unit or a pediatric intensive care unit, and when they might need escalation to the point of needing intubation, and when you need to get an ENT surgeon involved. So that's all I want to say about upper airway obstruction. Again, the clinical signs are what's important, and to learn how to identify those clinical signs will really help you if you see a child who's got severe upper airway obstruction. So that's all I'm going to say now. I'm going to stop the recording and happy to answer any questions that you might have.